When we have these people that we find in the evals that are at that marginal borderline, and really any little thing could really tip them over to the other side, and we tell them to slow down, whatever, and then the follow-up visit, their often comment is, I feel lazy, I feel guilty, and it's just a whole different. It impacts not just. It just impacts who they are, because that's not who they were. They're the ones who do that extra mile when nobody else would, and now we're telling them, just don't even try it, don't even attempt it, and it just kind of impacts their whole, perception of themselves. And I think that's a very difficult thing for a lot of our patients to handle. Though on a logical level, they understand this is what I need to do. And in our evals, we often try to actually involve the patient's family and so forth. And we tell them, look, 3 means 15% of normal strength. 100% is normal, you have 15%. And that seems to make a pretty significant impact on family members. It's like, oh, well, you look so normal, you're walking around doing this stuff, but boy, you're 15%, I think what I want to focus on is to let the community, the whole polio community, and also the medical community know the importance of what muscle testing really is. It can help risk stratify who's going to be, more in trouble than others. It's going to help in terms of who can exercise, who can't, which limb can be exercised, which can't, and just the whole medical community. The muscle testing is sort of became a very cumbersome thing that not many people do, unfortunately. Physical therapist does them, but oftentimes it's not incorporated into the physician's plan of care. So I think having that having that, and also the concept of what would cause exacerbation of post-polio. How could you basically do things to prevent it from coming on as quickly, or prolong your stable function as much as possible.
All of our polio patients, they're the same but different. There's a lot of psychosocial issues that go along with our polio population. As everyone knows, is a very driven population, type A personalities, as they'll say, and treating them, there are similarities and dissimilarities, but the fatigue issue is a very prone thing with regards to our polio population that might be caused differently than in, say, a stroke population, where it's just that physical kind of demand that because of the hemiparesis, if that's the condition, that it's more fatigue due to the weakness of the muscles. With post-polio syndrome, we see more of a generalized fatigue that might not be indicated by weakness. So that's a struggle that the patients have, and we have too, and with regards to treating it. So it's the energy conservation and management techniques, and I like to push on patients. It's more, I want you to come out of here doing more of the things that you want to do, and less of the things that you feel like you have to do. And we try to give them avenues of how to lessen the things that they feel like they have to do. Whether that's using some different grocery shopping techniques and ordering them online, which we have, and they deliver it to your home, which is inexpensive, but people might not think about that. Whether it's picking out the clothes and getting the laundry set the night before, so that in the morning you have less things to do before you're running off and trying to get to work. Letting patients know that it's okay to change their job and to take on less responsibility, and that they need to preserve their health. As we talk about, conserve it to preserve it instead of use it or lose it. So it's a change in how they approach their daily routines and the energy conservation. And we talk about an energy budget, that you only have a certain amount of energy for that week. How are you going to budget your energy for that week so that you don't use it up by the middle of the week, and this way it could extend throughout the week and you don't have that setback that we see in our polio populations that we might not see in the stroke populations or other injuries. That feeling that you have less muscle fibers that are around, and that if you tax the ones that are remaining, that you're going to lose them further. That's more unique to polio than it is for the stroke population. So I think it's more imperative to let them know you can't just exercise, 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 and expect to gain that strength back, and that could actually be harmful. And when you say that to a patient and they're looking at you and they say, but I want to make it stronger, I love doing my 3-mile walks and I want to continue to do my 3-mile walks so I can always do that, we try to get them to step back and say, well, if you keep doing those 3-mile walks but you're not able to do your other daily functions during the day because you're doing that walk, that's a poor choice. So we put that out there and we have patients make choices, and it is their choice. We can give them suggestions and say, well, in all the polio population that we've treated, we know that if we limit the overuse of these muscles, that you're going to be better off in the long run. And that's why when you've spoken to the physical therapist, they do have a polio-specific exercise program. It's not a program that says, no, if you have right lower extremity weakness, do not exercise. It's just exercising within parameters. So it's us trying to set those parameters, and the therapists have specific parameters that they go by with the 1 repetition max and trying to do non-fatiguing exercises, teaching the patients, well, this is the warning signs. If you're over-fatiguing a muscle, this is what you're going to see. Back away. Definitely continuing with a stretching program, because if you don't have the length in those muscles, then that's also going to affect your strength and how effective you can use those muscles. So yes, it's not all or none. It's not exercise or don't exercise. It's moderate exercise is going to be the plan, but the 3-mile walk might be too much. Doing the stairs and having patients tell us that, well, I go up and down the stairs because that's my exercise that I like to do. And we say, no, that's the wrong exercise. This is the type of exercise you should be doing. So it's more education of how to redirect their focus of their exercise. And if their arms were unlikely affected, then using their arms to get the cardiovascular exercise that's necessary, and not using their legs for that cardiovascular exercise. So there's the balance of, well, where are you getting exercise from, what are your goals, and then just educating the patient whether that's an effective goal. Acupuncture, particularly for pain management and pain control, is what we would see that other than healing factors of acupuncture, it's more for pain control. For me, manipulation is a strong thing to be used in the polio population because of their abnormalities in their gait and their biomechanics, that often there's restrictions of motion in other areas that if I can resolve by doing manipulative treatment, then they'll be better able to ambulate in a more effective manner, might tolerate their bracing better, have a decrease in pain, increase in their breathing ability if they had any kind of breathing problems with regards to their polio, improving respiratory drive. All of those things have been proven effective with manual medicine or manipulation. Can't tell you that there's specific studies that are involved for the polio population with regards to that, but
maybe there's another research.
Yeah. So there's, like I said, there's a lot, because there hasn't been a lot of research done in the polio population. Yeah, there's lots of avenues to go, but having more people involved in trying to set up those protocols would be, I think they're difficult. Manipulation in general is a tough thing by a research study to prove. Then if you throw post-polio population involved with that, it's going to make it into a very difficult project. I more check for how my patients are doing, and clinically, do they feel like it's beneficial? And the overall consensus has been yes, they feel like that's an adjunct to their care. It's not their only thing that they do, but it is. Well, myself, I do osteopathic manipulation, so I'll use that. We have a massage therapist here as well as acupuncture within our group. So I believe that having those alternative treatments are necessary and effective. I use them myself. Within a 3-day meeting, it's hard to take on all of that as well, but absolutely I would have the patients look into that and introduce any of those treatments that they feel were beneficial. I think that they should try everything they can to find other modalities that might be helpful, because medications with the side effects and the other fatigue factors that we have, we would like to avoid as much as possible. There's a big dispute with regards to EMGs and post-polio, and should they be done. My feeling is I'm a little softer on that I don't believe that it's necessary for everyone to have an EMG. Even EMGs with regards to was a limb ever affected have not been proven to be 100%. So if somebody had their legs affected and we're doing their arms and we don't find it, we can't say 100% that there was not evidence of old polio. We can make a statement that we believe that we don't see any affected groups and everything looks normal at this stage, and we can make the call on that. Otherwise, the only thing that we use the EMG and nerve conduction studies for, I mostly do it for the unaffected limbs, say in the upper extremities, to say, is there another process that's going on that might inhibit us from setting them on an upper extremity exercise program if their legs were affected. So if I do find a peripheral nerve problem such as a neuropathy or a nerve entrapment, we can treat it aggressively quicker than waiting for it to be a problem and then waking it up by the exercise programs that we give for the upper extremities. So I find it more important for our patients that have relatively unaffected upper extremities that I want to rule out treatable cause first that might limit them from doing that upper extremity program, more so than saying that there was absolutely no evidence of old polio, because I think that that's a misnomer. I don't believe the research bears out that that's 100%. Our therapists wait for me and they like to see that I write that I didn't see evidence of old polio in the extremities or in the upper extremities, so that they're able to do that exercise program. That's kind of their green light. But in my view, and looking at the research and also our director of EMG from our program, I've spoken with her about that too, and she's she's in agreement that the EMG has a questionable need with regards to treating post-polio patients. And I'd probably fall more towards that. So I don't think that it's imperative that everyone has an EMG and nerve conduction study. The majority of them have gone through it for their diagnosis of polio when they were younger. They had a bad experience with it. We try to make the process as benign as possible. If they choose to opt out, I don't believe that that's a detrimental thing, though I haven't had a patient refuse a study or stop a study by doing it, because I do limit the study to only answering those specific questions instead of checking 3 extremities and doing an extensive needle exam. I just don't find that that's necessary unless there is another problem that I was trying to rule out.
People who are responders, and that's an example of what I mean when I say I don't think we've really, teased out all of the underlying issues. I mean, post-polio syndrome is a bit of a wastebasket diagnosis. So people come in and they say, gee, I've been getting weaker over the last 3 years. Well, I mean, I think when you really look closely, I think some people get weaker in a different way than others. And some it's kind of pretty progressive downhill, and others it's more like a stair step. Some kind of get weaker for a while, and they stabilize, and then they actually get stronger again. And that weakness might just be disuse. Sometimes you find out that they've changed the way they work. I mean, maybe they're doing more of a desk job, less walking around, long hauls at the office. And, less exercise, you can get a little weaker. So, it's just, I think there's just a lot we don't know, and probably never will. My feeling is very strongly that folks that have polio pain, I'm talking about the deep muscle pain and maybe the joint pain in weight-bearing joints, usually because the muscles supporting those joints have gotten weaker, that kind of pain is generally very treatable, but never with medication. So I'm an absolutist about that. If somebody comes in and says that their legs really hurt them when they, walk a long distance, and for some people a long distance would be a block, and for others it might be 5 blocks, or for some people it might just be around the house. But if there's a clear history that they've got muscle pain with weight bearing, with prolonged weight bearing.
Stop bearing weight.
Yeah, it's a no-brainer. It's a no-brainer. But you'd be surprised at the number of people who just struggle to find some way to stay on their feet. I mean, I understand where they're coming from, but on the other hand, if the pain is really, if it's bad enough, you know, the old saying, you know, pain is nature's way of telling you to slow down. And the same thing is true of weight-bearing joints. Or of your shoulders if, you know, you're pushing a wheelchair or lifting heavy objects for whatever reason. I mean, that's just a no-brainer. The difficulty is getting patients to accept it. So, yeah, I think the worst thing you can do is give somebody strong pain medication to hide it, to cover it over, because you're not treating the problem, you're treating the symptom. And I talk about this in the book. I mean, I think there's some very specific types of polio pain. There's a muscle pain, which tends to be deep and aching. There sometimes is a more superficial pain, which almost seems like it's on the skin, which is more of a burning pain. My feeling is very strongly that folks that have polio pain, I'm talking now about the deep muscle pain and maybe the joint pain in weight-bearing joints, usually because the muscles supporting those joints have gotten weaker, that kind of pain is generally very treatable, but never with medication. So I'm an absolutist about that. You know, if somebody comes in and says that their legs really hurt them when they, you know, walk a long distance, and for some people a long distance would be a block, and for others it might be 5 blocks, or for some people it might just be around the house. But if there's a clear history that they've got muscle pain with weight bearing, with prolonged weight bearing,
Stop bearing weight.
Yeah, it's a no-brainer. It's a no-brainer. But you'd be surprised at the number of people who just struggle to find some way to stay on their feet. I mean, I understand where they're coming from, but on the other hand, if the pain is really, if it's bad enough, you know, the old saying, you know, pain is nature's way of telling you to slow down. And the same thing is true of weight-bearing joints. Or of your shoulders if, you know, you're pushing a wheelchair or lifting heavy objects for whatever reason. I mean, that's just a no-brainer. The difficulty is getting patients to accept it. So, yeah, I think the worst thing you can do is give somebody strong pain medication to hide it, to cover it over, because you're not treating the problem, you're treating the symptom.
Okay. Would you be comfortable explaining how you manage your own condition? You don't have to.
Yeah.
So you started experiencing the first symptoms of post-polio at what age?
Well, it was...
Because you had polio at 18.
Right. So it was about 30 years later, so I must have been...
In your late 40s?
Yeah. It came on relatively quickly, you know, over a period of several months. And as I mentioned, it wasn't the heavy legs that I felt first. The first thing was extreme fatigue, which I had never had before. You know, all through college, through medical school, through 4 years of internship and residency, working every other night, every other weekend. I mean, very, very intense, labor intense. But, you know, I was able to keep up with my colleagues. And I tended to have fairly intense jobs after that. And I used to play a little tennis. I did some jogging. I mean, I was trying to stay in shape. I would jog upstairs.
I read in your book that you could out-leg wrestle
Oh yeah.
your
was-
wrestling
That-
colleague,
yeah,
or
the
whatever he did.
Soccer playing.
Yes.
Yeah, roommate, right. I was in college. Yeah, my legs were very strong, and the thing is, I used my legs to sort of supplement my paralyzed right arm. So I mean, I would lift things with my legs. And anyway, so yeah, I was driving home one day back in I think late '82, early '83. I'm not sure. And I stopped at a red light and I fell asleep. Never done that in my life. And I woke up pretty quickly. It wasn't a problem. But I realized that that part of the day I was getting very tired. So on the way home, I just pulled into a parking lot and I'd sleep for 10 minutes or something, and I was refreshed. So that was my first symptom. And of course, I had no idea what the hell was going on. And then the next thing I knew was I was feeling my legs were heavy when I walked long distances, 3-4 blocks, say, which I used to do multiple times a day, and I worked in a hospital and walked long corridors, no trouble. And then I started to get very, very intense leg pains in my thighs, which help stabilize your knees when you're standing. And
Were you taking painkillers?
No. But I had no idea what was going on. But as it turned out, I was working in a hospital that had been a polio respiratory center. Marcia Dimes helped pay for about 15 hospitals around the country. They were called respiratory centers. And some of them survived, and then they became just general rehab hospitals, and that was the case for this one in Houston, Texas. And there was a physical therapist from the polio days who worked there, older woman. And so I saw her one day, and I mentioned that I was getting these bad pains in my thighs. And she didn't know anything about post-polio syndrome. I mean, that term had not been coined. There was nothing in the literature about late effects of polio, with one or two exceptions. But she was just the savvy clinician, and she said, "You need a wheelchair." Or I think she said, "You need a scooter." Basically, get the hell off your legs. So I actually got one. I mean, pain really does cause you to change your behavior if it's severe enough. I got a scooter. It's the same one that's sitting out in the hall. 25 years old. And it still clunks along. But within 3 days, my pain was gone. And so what's happened over the years is, so then for a bunch of years, I was able to walk comfortably outside the hospital. And eventually, about 15 years ago, I was beginning to get problems just with, walking around the house, community walking. So I got another scooter and a van, which I have now. So I can load the scooter in the van and carry the scooter with me.
You lift it? You don't have a hoist?
Yeah.
Yep.
Yeah. And then more recently, I got the third scooter, which I have in the house, which I don't use too much right at the moment. But in any event, that's sort of, you see that sort of progression.
You don't have respiratory problems at all?
I don't.
Sleep apnea?
No, I've had 3 sleep studies. Because I was in an iron lung, so I thought I'd be a candidate, and maybe in the future. But, So, I still, the distance I can walk comfortably gets, shorter and shorter, almost year by year. And, you're very tempted to, if you're feeling rested and your legs are feeling good, you go 10 steps, 20 steps, 50 steps more than you probably should. And then my legs start hurting. So, I'm still dealing with the same issue but in a much different dimension than 25 years ago.
What do you do for exercise?
I'm one of those ones that doesn't have any muscle exercise. I do stretching. But my left arm is weak from the original polio, and it's getting a little weaker. And for me, walking around, the little bit of I do is my leg exercise. That's it.
Do you have any thoughts on the theory behind inflammation, the inflammation theory of post-polio, how that can actually exacerbate the issues?
I don't know about exacerbating. There is some suggestion that there might be an inflammatory component. I don't know if it's from sort of the residual damage to the spinal cord. There's dead tissue that's provoked sort of a low-grade smoldering, as opposed to a fresh infection, say a viral infection or something. If that were the case, it would be more likely an immunologic thing where the virus might trigger something that attacks the body. I mean, that's the theory that the Swedish folks were going on when they used the immunoglobulins. And, their first finding was really very exciting because they found in the spinal fluid of folks that had PPS elevated what are called inflammatory cytokines. And they didn't find that in folks that have polio but no new symptoms. So that's what led them to think, gee, there might be something, either inflammatory or autoimmune going on. And then when they gave immunoglobulins to a few folks, they seemed to get better, and that provoked then a bigger, randomized double-blind study.
Mm-hmm. Are you interested in sort of like specifying anything else that you found, in the years that you've been working in the area, any personal experiences or anything that you feel is really important, another important take-home message for managing post-polio?
The manual muscle test is almost worthless.
Please explain.
Well, I wish I were younger and had more energy because this would be a project worth doing. Particularly if, there were a lot of, younger polio patients coming along. Well, I mean, we kind of know some of the pathology of new weakness. There is a problem at the neuromuscular junction. And we know when you take a history, people will tell you, I can walk fine for 2 blocks. 5 years ago, I could walk fine for 10 blocks. If you take that person and test their muscle, just say knee extension, where they kick their knee out, primarily the quadriceps, and you give it resistance. I mean, what a therapist does when they test it is they ask the patient to make a maximum contraction to resist it as hard as they can. So what you're doing is you're recruiting a lot of motor neurons, okay? Mm-hmm. The thing is that with somebody who doesn't have a polio insult to the spinal cord is they have got this enormous reserve of neurons they can call in. So they can make a very strong contraction. Now, the polio person's contraction might be as strong, but they're using absolutely every last motor neuron in the neighborhood. Okay? The guy without the polio is doing it, and he's like, it's all the reserve forces. Mm. So the thing is that when you then ask the polio patient to contract again, it may not be quite as strong. And maybe you can't tell that, but if you put them on a machine, it would show. And you ask them to repeat it. On the 5th time, you begin to feel it ain't quite as strong. By the 10th time, it's quite a bit weaker. By the 20th time, they can hardly bring their foot up in the air. Now, that's an example, and it may be a bit of an exaggeration to make the point. The thing is that the polio muscle tends to be poorly innervated. often looks like it's normal because the person is using it sort of at a super normal level. And Jacqueline Perry certainly has talked about this, and a lot of folks who have done electrodialysis studies have talked about this. So, given that, I'm not sure that the manual muscle test tells you much about a person's progression, disease progression. The history is often the most useful. So I always ask people, how far can you walk a day? And compare that to 1 year ago, 3 years ago, 5 years ago. How many stairs can you climb? How long can you stand without having to, look for a place to sit? Today compared, in the past. And that will often elicit a very clear picture, of a decline. And I think the manual muscle test, if it were done in a different way, could demonstrate much the same thing. So it would be how many repetitions with full resistance can they do, with a certain muscle group before they start to fatigue.
The first person that we ever treated agreed to everything. She got a power chair, she cut back on what she did, she got someone to do cleaning, laundry, her kids were on board, her husband was on board, and she is better now, 25 years later, than she was the first day that we saw her. And when polio survivors stay on the wagon and take care of themselves, they do fine. We don't see folks who are taking care of themselves come back 10 years later and say, oh my God, my rotator cuffs are torn and, my hip is shot and whatever. They do well. The people that come and literally tell me to go to hell, no, I'm not going to use a cane, crutch, wheelchair, you name it, come back, some of them, a percentage of them, 10 years later, 15 years later, in the wheelchair that we recommended because they can't walk anymore, or with some kind of assistive devices, or even having had surgery. One poor guy got both of his knees replaced, the doctor promising him that he would walk once the knees were replaced. Nothing wrong with his knees, he's got no nerves running his legs, so that's like changing the tires on a car that has no motor. It's still not going to run. So I guess the bottom line to people who have polio now, and for the people who had polio before, is that they've got to listen to what their bodies are saying and respect that and care for themselves the way they've been caring for everybody else in their lives. They see the dietitian who talks about what they should be eating, and the study we did about protein, and again, that's not rocket science. If you don't eat breakfast, you have coffee for lunch, and then you have a piece of cold pizza for dinner because you have to run out to a meeting because you're the mayor of the town, that's not consistent with life, let alone polio. And the fact that polio survivors are hypoglycemic, have low blood sugar, and their neurons run on blood sugar, well, you're going to need something to fill their tank first thing in the morning and to keep the tank filled throughout the day. And if they get the number of grams of protein that they need for the body weight that they want to be, they do just fine. And it's, again, it's another, miracle treatment that we've discovered, food. And I can't tell you the number of people who've called who've come for an evaluation, and that they have, just overwhelming fatigue, and they're weak, and they get washed and dressed, and then by the time they get to have breakfast, they're so tired they can't. And they come for an eval, they call the next day, like around noon, and they say, oh my God, I feel wonderful, I have energy. Well, why do you think this happened? Had breakfast, had 18 grams of low-fat protein for breakfast, had a couple of eggs and a glass of low-fat milk, and
Instant fix.
Yeah, very quick.
Parkinson's community and the MS community, there are specific exercise classes that are designed for their needs. In MS, you want to avoid overheating. In Parkinson's, you have to respect the fact that these people have, mobility and balance issues that are really going to limit what they are able to do. Someone can only exercise sitting.
Yep.
So I often will take advantage of classes like that. I think classes designed for people with arthritis, there's probably too much repetitive movement, and repetition fatigues people.
Use it all.
But for the Parkinson's group, for the MS group, I think there are some classes that could be beneficial and less likely to cause harm. There are also some good exercise videotapes that have been developed by the Parkinson's Association. We did one for people with balance disorders, never got it marketed, but we worked on that one together. And I think you'll find a lot on the internet, and I know that there is some interest in the Parkinson's community, which is a very large community of older people, in getting things that can be done together in groups, getting things that can be done individually, videotapes and other things. Yoga classes are very popular and can usually be designed to respect the limitations of the person participating.
I think it has to fit the person and their needs. And sometimes the people are so anxious to get something to help them stand up or walk or be more stable that they say, yeah, I'll get it, and then it turns out that it doesn't really suit their needs. So I think it needs to be a collaborative effort with a prosthetist, orthotist, and a PT, as well as the physician.
We really look for dynamic bracing. So obviously the material is important. It has to be lightweight, it has to be somewhat flexible, you have to be able to modify it if you need to do a change, opposed to making a whole new brace. But it needs to support the muscles that need to be supported. It needs to not limit the muscles that are still functional. And it needs to give a little dynamic support to the muscles you want to give a little boost to. And it may be a jointed brace, it may not be a jointed brace, it may have different materials in it, and it really has to be individualized. And I think the braces that end up in closets are the ones that are just, kind of cookie cuttered out from standard orthopedic designs, and this is not what you need for neuromuscular bracing. Some patients could never find a solid material brace that worked well, and they've resorted to using like ace bandage wraps that they themselves will kind of wrap around a joint or wrap around an area to support it, and it works just as well as an expensive brace might for that particular individual. There's an enormous amount available for pain management, and a lot greater knowledge in the medical community about how to utilize pain management techniques. You don't even have to go to a multidisciplinary pain center if you just know a few simple things. Number one, figure out what's causing the pain. Polio survivors can have 4 different types of pain or 5 different types of pain. This was written up by Dr. Gaughan. I did a beautiful article about pain in post-polio. There can be, very simple neuromuscular pain, neuropathic pain, tingling, numbness, other uncomfortable sensations. There can be muscle-mediated pain from trigger point activity. There can be sprain and strain pain, looking at joints and ligaments and tendons. And then there can be orthopedic pain within the joint itself. And each one of those types of pain is managed differently. So, often physical therapy has techniques that can be helpful in managing each of those types of pain. Certain medications can be helpful for neuromuscular pain. There are a variety of medications in the anti-seizure medication family and in the muscle relaxant family, including things like baclofen, which is sort of well known, and tizanidine, which can be extremely helpful for neuromuscular pain in neurologic patients. When you're dealing with painkillers that don't work with the mechanism of the pain, but just block the pain at the level of the opiate receptors, you have to be very careful in how you use them. You have to set limits to how they're used. You have to make sure the person knows what those limits are. You have to recognize when your painkiller is not working and the dose is accelerating because it's just the wrong thing for the person to be on. You don't want to have somebody on daily painkillers because they quickly lose their effectiveness and people become tolerant to them or even addicted to them. So medication management, choosing the right medicine, choosing other non-medical strategies, the psychological input, the rehabilitation input, proper adaptive equipment. I had a woman with killer back pain because of spine-related problems. The only thing that reduced her pain to almost zero was a good fitting back brace. Nothing, medicines didn't work, nothing else worked. So you really have to take it apart, look at rehabilitation, psychological, painkiller medication, antispasm medication, other medications, acupuncture, the whole range of services. You don't want to get involved in serial monotherapies where you try one thing, it doesn't work, you try something else, it doesn't work. You sometimes have to use a combination of strategies. Very careful using muscle relaxants. Traditional muscle relaxants that work on the muscle should probably not be used in post-polio or be used very carefully because there's greater risk of causing muscle weakness. Some of the ones, though, that work on the nerves and relax muscle spasm by modifying nerve input, I think can be used carefully, and specifically baclofen and tizanidine can be used in small dose and can be quite helpful. In somebody who's having generalized muscle pain, maybe relating to overuse or just weak muscles that are reacting to the pull of gravity, it's unlikely that you will find a pain medicine that will take away 100% of their pain. So you're always going to have a little bit of pain left to act as a barometer for when you're doing too much. Also, if you're doing something and there's an increase in pain that follows the activity, if that even small increase in pain persists for hours, again, it's a barometer for overuse. So you don't want people to suffer. You want people to be able to do more and not be limited by pain, but you have to educate them about the clues that they should look for to avoid overuse, because you're trying to avoid overuse. That's the main thing you're trying to do.
And I was the head of a virus lab where we were doing research with virology and wondered what on earth was wrong with me. The internet was just coming into being, and using a combination of information that I had plus the internet, figured out that what I probably had was PPS. So yes, I'm sure that that's what I had. And I started on the downhill slope that most everybody's familiar with, where fatigue and muscle weakness, new muscle weakness, then increased fatigue, increased muscle weakness. I started tripping, falling. I wound up having to lie on the floor to take a nap in the middle of the day in order to function. It was a standard story. And it got continuously worse, slowly over a period of years, so that I went from an AFO to a KAFO because I couldn't stand for any length of time. I went from using a cane to having a scooter for long distances, and it looked like life was going to be pretty grim, and I was pretty annoyed with the situation. So I decided to research it. So I did. I dug into what was known at the time about PPS. Now, by now we're talking, the year must have been about 2000, thereabouts. And I did a lot of research along with Eddie Bolenbach, and in fact we even did a survey, and we got a lot of useful information from this, and discovered basically that underlying PPS, as well as underlying all chronic disease, is inflammation. Usually subacute, but doesn't have to be. It's a case of chronic inflammation. So I took the knowledge that I had and I used anti-inflammatory techniques, tricks, but not overt medication other than aspirin. And over a period of 3 years, and it was 3 rigorous years where I really stuck to a regimen that I had developed to combat inflammation, I started to see improvements. And so now it's, 2008. I no longer wear the AFO. I still do get fatigued. I still do have some muscle weakness. I've learned how to cope. I do use pacing. But I'm also a lot better than I was. So that's kind of me in a nutshell. So what did I do? What areas of stress did I work at to reduce inflammation, which in turn enabled me to have a better quality of life? Well, I'd like to be able to tell you that there was one at a time, because as a scientist, one should only work on one variable at a time.
That's not life.
Unfortunately, I tend to go for the full bag right away, and so I can't actually pinpoint one, but I can tell you what I did. I decided, if you're a scientist, you pick one thing. Let's say you decide to raise your glutathione levels, for instance. So glutathione is an amino acid that is vital for the proper function of your immune system. And as we age, we produce less glutathione and also absorb less from our diet. So the immune system is working at less than optimal. Now, the immune system has two functions, by the way. It both turns on and turns itself off. So when you say the proper functioning of the immune system, it means that the immune system retains the ability to reduce its activity as well as to increase inflammation. It can and must, and in fact it must reduce inflammation at the same time. Okay, so let's say that I decided a proper scientist would only supplement themselves with more glutathione for a period of, an arbitrary period. Let's say they might say 3 months, because that would be a fairly decent interval to see if there's any body response.
What is that?
What is glutathione?
Where do you get it?
Oh, well, it's an amino acid, and it comes from undenatured whey protein. That's the best source. I mean, there are other sources, but undenatured whey protein is a source of, readily absorbable source of glutathione. It's in meat, and it's in milk, and it's in other things too. But as I say, as we get older, our intestines don't absorb as much as they did. So this also helps to explain why PPS tends to strike later on in age, because the body is, well, aging, but things are not as optimal as they were when you were younger. So, okay, so back to whey protein. So I should have done that, but of course I couldn't do that because I knew that that was one thing that would work. But there are many other things that would be useful too, not the least of which, in fact the most important of which, is the amount of visceral fat that a person carries, the amount of fat that you carry around your organs. So it meant that I needed to reduce fat. And the best way to do that, of course, was to look into the various ways of not just diets, but changing how you eat, which brought me to the glycemic index, which is another whole story. And then, the same time as that, and tied in with that, is insulin resistance. So this is all of this is now combined in one package, and that's what makes it really hard to tease things apart. The whey protein is kind of by itself. You can say, okay, that's a specific thing. It doesn't really impinge much upon fat or the activities of fat. But all the rest of things, reducing weight, the glycemic index, insulin resistance, those are all very closely entwined. So I attacked that. And then perhaps the most important one, and the one that is in some ways the easiest to do and in other ways the most difficult to do, is to attack your stress levels. And the best way to attack stress level is any one of the types of meditation that are available. So yoga is a very good form because it combines both meditation and physical exercise. If you get the right kind of yoga, there's many kinds of yoga. Just straight out meditation, where you just sit quietly and try to empty your mind of all thoughts, that works beautifully. Guided meditations are probably the easiest things to use for people, and there's tons of tapes and CDs and people out there who are only too happy to lead you in a guided meditation where you walk down a lovely path and you sit among whatever, by the ocean or among roses or whatever turns you on. And those are great. They're really good. In fact, I would recommend starting with them rather than just sitting there staring at a candle flame trying to empty your mind. That doesn't work too well at first. But meditation is the single most important step in lowering inflammation. And it's also the most difficult to do. Just because nobody has time. Or you put it off. And it's so easy to say, well, what's it doing? I mean, I'm just sitting there. But there's lots and lots of studies to show that it is the most effective way to reduce the immune system overaction or overreaction. It reduces the stress hormone levels immediately, and far better actually than drugs. And drugs all have side effects. Another area in your ideal clinic, You need, are you ready for this? You need an alternative, what should we call them, alternative person? No, you can't call them alternative person. Obviously this is somebody who knows how to lead a yoga program for people with PPS. This is somebody who knows how to introduce meditation and who's willing to help people through the difficult stages in the beginning and then get them over the hump when they relapse and say, I can't do it anymore. I see clinics as a way of promulgating information. That's very important. And promulgating accurate information, that's exceedingly important. So the whole idea about pacing, interestingly enough, is right on. It's absolutely correct. It's not only has it been shown many times by many people to be very effective, but there's good evidence why it works. For instance, when you overstress a muscle, you cause inflammation. So, of course, there's a problem there. So don't overstress the muscle. In other words, pace. Know your limits, learn your limits, figure out where they are. That said, know your limits, learn where they are, and then try to push them a tiny little bit. That's my personal opinion. A tiny little bit. And then back off. Because you'll find out whether you can or you can't. If you have an adverse reaction, if you have fatigue, if you have extra pain, back off. Don't do it. But sometimes you're surprised, and you can actually push that boundary a little bit further. And then leave it there for a while, and then push it again. Because you can at the same time strengthen muscles. Especially once you reduce inflammation, your muscles regain some capabilities that they had previously lost, simply because the innervation is there for a longer period of time. So you shouldn't always accept the fact that you're going to get weaker and weaker. That's not the case. At worst, you may stabilize. Quite often you actually can get some new strength back with careful and appropriate exercise. So there is the clinic's job too. What is careful, what is appropriate exercise for each individual? Because not everybody can figure that out, and you can always use advice. So again, that's the role of the clinic.
With my time at the clinic, we did a pilot study looking at yoga and post-polio. It was actually a combination of yoga and a chronic disease self-management course, which helped people to look at setting appropriate goals, managing their health care, and that was developed through Stanford University and is essentially applicable to anybody with chronic disease. The yoga portion of things was, again, I started out as a skeptic. I knew very little about yoga, and what I did know, I didn't see how these folks in wheelchairs or who were getting around with crutches and braces were going to be able to do yoga. Well, I was amazed, and we had a retreat where individuals went through the course and also were taught basic yoga, which was individualized to their needs. And yoga, as I'm sure you know, is a very key part of that. Is looking at is looking at relaxation, breathing, and things like that. And these are new skills to some of these individuals, but in that setting, especially, it was a phenomenal event because you had these individuals who were living with their polio and post-polio issues in isolation, and they all come together. And in that setting, it was kind of okay to look at some of these things. I dare say that any one of those individuals, had we seen them in the clinic alone and suggested yoga, it might not have kind of flown quite as much as it did in a group setting. And they took it very seriously. And again, I'm not very good at recalling the numbers, but I'm sure they'll share the study results with you. But it was phenomenal. 6 months later, we had the majority of patients were still doing their yoga. This is 6 months after the study ended. And you don't see that kind of compliance out of healthy individuals with a basic exercise program. So, and there were a number, just anecdotally, there were a number of people who would come back a year later and talk about that as being a pivotal turning point in their life. And they pointed specifically to the relaxation as being the key for them. And so that goes very much hand in hand with the sleep issues. I thank you for the segue there, because it is so important to be able to balance out that drive with the ability to have relaxation. And in no way am I saying that I think people are overdriven or they shouldn't be who they are, but it's important to have that balance. But as a general principle in this population, I don't doubt at all that relaxation therapy, eliminating stress, improving sleep, can have a profound physiologic effect, which would be more of a direct effect as well as the indirect effect. And what's contributing to what, I don't think anybody will ever know. But when somebody is able to deal with stress better, for example, when you look just at sleep, individuals who go to sleep with stress on their mind will have a different EEG overnight. They'll have a different sleep architecture. They won't get down in a deep sleep as much as somebody who's relaxed.